Good afternoon. Today we have Andrew Codlin with me. He's an M&E Director of Friends of International Tuberculosis.
Yep, fit to.
Yeah, from Vietnam. I know him, Andrew, for last probably 10 years plus.
Yeah, I think so.
Yeah, in multiple roles. We work together for Zero TB Cities and when you are in Stop TB Partnership. He's a global TB expert, also like a part of many WHO consultation and groups. And Andrew, just explain that what you're doing in Vietnam and your experience with integrated lung healthcare using AI, chest X-ray AI reporting.
Yeah, so I run an organization which does a lot of TB prevention, treatment and search services. And one of the things that we've been doing is a lot of community-based active case finding for TB. And in the past year, we've been using this enormous library of chest X-ray images generated from our TB screening to now make CAD-assisted CT referrals for early lung cancer detection.
Okay, so you're using retrospective X-ray scan repository?
No, we're continuously generating these X-rays through our community work, and every week we're making referrals for CT scans.
Okay, do you have so primary aim of this thing is like leveraging the TB program X-rays to detect more diseases, correct?
Yes, exactly.
Do you have any numbers to share with us?
So I think that in our community work we've done with the lung cancer screening about 40,000 plus chest X-rays in the community for TB screening, and that has then generated, with some challenges with implementation, about 100 and maybe 200 CT scans.
Okay. But there might be significant leakage from identification, getting it tested and profiled and CT scans, right?
Yeah, we've had a big challenge with people accepting the CT referral. Many people have said they don't want this screening service, they don't like the disease, they're afraid. Some people have actually told us they already know they have cancer and they don't want, they've elected not to take treatment. They're too far away and so on. So there has been a lower than expected acceptability for the community referrals. But at the same time, we're doing hospital referrals as well, and that has had very high acceptability.
Okay, so the community probably might have been asymptomatic people.
Yes.
Yeah, so they're not expecting, I probably might have screened for tuberculosis. Now they're saying I have cancer, right?
Yes.
Yeah.
Well, we were very careful with the way that we communicate with them, and we say, we've reviewed your X-ray, we found some abnormalities that we'd like to continue investigating and so on. We're very careful not to say we think you have lung cancer. But these people in the community are, for the most part, feeling healthy, and they've just received a negative TB diagnosis. So maybe in their mind the evaluation is over, the health check is over.
That's a great insight. While you are designing integrated care, you probably need to think about the adaptability part. How do you prepare health system? How do you prepare patient side? Are we clear on the pathway of care being defined? What are the challenges and leak outs, and how do we mitigate it? It's a wonderful point, wonderful learning actually. So Andrew, being in the active case finding space, I would classify you as an active case finding expert, because the day I met you and probably we interacted was in the context of active case finding. So how do you see this active case finding domain evolved over the years? Probably starting from scratch of referring cuff officers to now technology-driven conversations. Could you please update me about all this?
So I've probably been doing this, I think, for close to 15 years, kind of that community active case finding work. So really, we started with screening referrals for cough using like Nokia phones to systematically try to screen people. And it's just rapidly and changed enormously. We now have ultra portable chest X-rays that are very small, tiny. They're easy to move around. We have the CAD solutions, which can really help with ensuring the quality of that read, making sure that we don't miss anybody, quick turnaround times, things like this, and following them up with really high sensitivity and specificity molecular tests. So we've been primarily using expert in Vietnam, but now we're starting to use Mobile, and there's also a Korean platform called TRC that we're using as well. So really good quality PCR tests.
Okay, so you kind of probably moved from a medieval
Yeah.
case finding to a much more futuristic.
Yeah,
on the
for sure.
Pathway to a futuristic case
And we've done it in stages. You know, there was a time when we did some screening on an island about 8 miles off the coast of Vietnam, and we rented a giant barge to put a big X-ray truck on there.
Okay.
And we were just nervous that it was gonna, you know, there'd be a swale and it would tip into the ocean. And now with the ultra portable X-rays, it's just so easy to get around and do the screening.
No. So when you mentioned about Vietnam, so it's incidentally we are sitting in Union, and Guy Marks have actually contributed a lot about population level screening, and that happened in Vietnam.
Yeah.
He probably just crossed the ocean and came down here and done all the studies.
Yeah.
So, I mean, are you kind of aware about, are you part of such population level screening, so continuous sequential screening in a population to drive down the...
So Wilcock and Guy Marks' team is very lucky. They have a nice sponsor and they're doing that continuous screening. We've done some population level screening, but we haven't had the level of support to do it on a really regular basis. We have one focus area on an island in Vietnam where we've done 3 successive campaigns, and we did it integrated with chest X-ray, with TPT. We used an ultra short TPT regimen there, and we're hopefully going to go back for a 4th campaign and see whether we've managed to eliminate TB from this island.
Oh, cool. So the other thing is also Vietnam was actually we're discussing about the Stop TB, Zero TB initiatives, right? I recall that we had consultations in Hanoi and Ho Chi Minh, and a couple of cities were selected for Zero TB initiatives. Is that activities are still on?
Yeah, I think that for us, that really was the impetus to kickstart the TB prevention in our settings. We had some, at the time we thought we had good treatment coverage. Prevalence survey has now shown maybe not true. But really that kickstarted the provision of TPT. And so we've moved away from 9-month and 6-month regimens down to 3 months. We've even moved from 3-month daily to 3-month weekly. We're about to start a trial now looking at 1 month in HIV negative individuals. So I think that the Zero TB component has kind of morphed into a prevention arm.
Okay, good. So just wanted to switch from the CAT to the private sector engagement.
Oh yeah.
So which I'm also in So I know that there are some elements of the private provider interface agencies has been kind of repurposed for Vietnam use, correct? So are you also using technology like CAD in that initiative?
So it's really been quite a challenge because there are a lot of data regulations and privacy laws and things like this. We did try to do a deployment in many different hospitals, and we got it working in one hospital, and the results are they're really fantastic. We've seen a 44% increase in TB detection due to the CAD software in the hospital.
And you're using QXR, right?
Mm-hmm. Yep. It's been very challenging to get the radiologists in Vietnam to collect sputum and test specimens, which they don't necessarily agree with. Okay. So it's been a lot of education and sensitization to make sure that the participants are really fully evaluated. But we've seen, especially in some of the PPM facilities, they just have such high volumes of participants coming through on chest X-ray that the reading is very fast and maybe not the best quality with the radiologist.
We are just looking only for tuberculosis here, right?
Yeah.
We're exploring lung nodule.
We did some of this in Ho Chi Minh City and Haiphong, which is Vietnam's 3rd largest city, using lung nodules. And I think that that's gone well. The hospital screening's been very easy to convert into CT scans and follow-on care, much easier than the community work.
Absolutely. So incidentally, we are also finding this incidental case finding when we did it in Mumbai. Mumbai Corporation has actually, through Stop TB partnership, deployed QXR in their heavy load facilities. And what we are seeing is that there is a 35% bump up in the case finding, which are all from incidentally kind from TB for pathway. But I completely agree with the challenges which you just mentioned, especially the leakages from identified to linkages to diagnosis and then subsequently to treatment. There's a whole lot of health system function need to be kind of geared up to cater to that. Issues of cartridge shortages because of their test went up and they were not able to catch up with that.
Yeah.
I think the way forward is more of like, okay, how do we kind of bump up the capacity of the existing facilities
Yeah.
with the AI as an enabler, and then get more cases out of it alongside your active case finding efforts.
Yeah, absolutely. You know, the people who are coming to that facility where we've operationalized the CAD software, they're not coming for TB screening. They're coming for other things, and we're catching TB as like as an afterthought, and catching lung cancer as an afterthought.
Advantage.
Yeah.
You do something else, and
Exactly.
Okay, Andrew, so you just mentioned about how wonderfully you kind of repackaged a solution which was meant for a TB to a much more double-click version of a lung health. And now you have defined two disease pathways in multiple settings, in the community setting, in the health setting, and you're also telling the world, hey, there are low hangings in health facilities, which is much more easy to define a pathway.
Yeah.
And this is how we need to do it. Wonderful talking to you.